This is our 5th session. So we are happy you've joined us today. So we'll go to the next slide. We've got our funding acknowledgement. Every session we tell you that this is an initiative by the Pediatric Pandemic Network and EMSC Innovation and Improvement Center. We're supported by HRSA. And the contents of the authors are of the authors and do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. So we'll go to the next slide. Again, thank you for joining us today. The session is going to be recorded. We've got the Q&A feature to ask questions. We've also got the chat feature. And we always say this every session. Today's session is interactive. We always have wonderful interactive sessions, but today is really going to be used as a working meeting. So if we go to the next session, on the next slide, we can see the session agenda. So we've broken it out. Hopefully you read your email and you are prepared for the hour and a half today. We've heard from you last time. Last session, we asked if you wanted to continue with the minimum criteria discussions as a larger group, or if we needed to break it down into subgroups. Well, we got a really, really close response. And there were about 24 of you that said we want to continue in the large group. And then 22 of you said we want to break it out into subgroups. And so to compromise and to meet everybody where you are, we decided that we are going to break our hour and a half sessions. We have monthly hour and a half sessions. We're going to break that up into the first 30 minutes is going to be talking about ED minimum criteria. Then we're going to spend the next 30 minutes talking about a topic to help you with your recognition programs and continuing that development and improvement. And then the next 30 minutes, the last 30 minutes, we'll discuss the pre-hospital recognition program minimum criteria. So you can join in the beginning, or you can join in the middle, or at the end. And so hopefully everybody will be there for the recognition program topic in the middle. But you have a choice of staying or going for the ED and or pre-hospital minimum criteria discussions. So if we go to the next slide, I will hand it over to Kasey and we can get the discussion started about our consensus activity.
Thank you, Julie. So as Julie said, we're going to get started with discussing the proposed criteria for minimum recognition programs for EDs. So you may recall, we've started the consensus activity and we have completed round 2 ranking and we are in the analysis of results and feedback stage. So we're going to spend our time here before we come back together with the whole group to discuss goal setting, to review the responses that we've received from the group. And you may have received this morning an email with your state's responses. If you weren't able to access that, or you didn't get that email and you're looking for your state's response, if you message Eleni, she'll help get you your state's link to your responses. And then yesterday, you would have received the overall responses and some comments just so you could have a record to follow along or to maybe see it a little bit more clearly as we discussed today. So if you need either of those links, go ahead and reach out to Eleni and she'll make sure that you get those as we're going through today. So again, we've did our round 1 voting, yes, no question in person, live during the session. And then round 2 voting was that red cap survey that was sent out. So we are appreciative to all those that responded, and we've compiled those responses and we're ready to discuss them today. So I'm going to show you some information. We'll do a little bit of orienting to the data we have, and then we look forward to having a conversation with you all about what recommendations you have to make edits to that criteria. because the goal for today is to just discuss and edit the proposed criteria in preparation for a third round, which will happen at a later date. So if we start by looking at the overall results for round 2, you can see the proposed criteria, and then we have the average, and the average was taken from each state and territory had 1 vote, and then we averaged all of those responses. And then we have the maximum score. So we asked you to rank based on 1 through 5. So the maximum score was 5 for all of the criteria in our round 2. And then you can see the average minimum score, and that ranges anywhere from 1 to 2. And then we took the range, or the difference between the maximum and the minimum. That's what you see on the far left of your screen. So again, you all should have a copy of this so you can see it in a little bit more detail, but we wanted to show you overall where we were at, and then we would like to start discussing that a little bit more. We've gone ahead and ranked these in order of the highest average with the smallest range. So that is the order in which the criteria is in right now in this table, with our highest average and our smallest range. So showing that we thought it was really important and that we were really close in terms of our responses, with the average score of being a 5 and the minimum being a 2, giving us that range of 3. Any questions about the table here or the results that you're seeing, or how we got them? Then I want to go ahead and great question. So the red font are the ones that we wanted to start with today for discussion. Those are some of the ones that we pulled out. We figured with our sort of condensed format to provide different sections today. Probably not gonna have time to discuss all of them, and we look forward to discussing more of them with you during our next session. But we would like to start with these today. So first one starting with is weighing kilograms only. So a couple hexagons, and you can see the average score for evidence, the average score for importance and feasibility along the top. And then along the bottom, you have your overall average score, the range of that score, and then the total number of responses we've received. So we did receive responses from 39 states and territories. The average score for evidence was 4.7, importance of 4.8, feasibility was 4.6, and then the overall average of evidence, importance, and feasibility is 4.7. And then we also have included some of the comments that we've received through sessions, as well as responses to the survey. Great question. Why weighing in kilograms versus pounds? Let's see, who do we have joining us? I don't know if Lisa or Kate,
Michelle or Lisa, either one.
Yeah.
Go ahead, Michelle.
So medication dosing for pediatric patients is all based on mgs or milliliters or mics, whatever you want to do, per kilo. And when you weigh in pounds, a lot of times when you're converting it from pounds to kilos, there's errors made by misputting the pounds weight versus the kilogram weights. And when that happens, you are actually giving at least a 2-fold dose, double dose of medications that are ordered. So it's really important to have scales that are either locked in kilos or figuring out how you can do that where just kilos is showing, or purchasing scales that, and most scales that I've found working, at least across our large system, the facilities people have been able to lock them in kilos to prevent those errors. Hopefully that makes sense.
Thank you, Michelle. We saw, some of the cons for including this as minimum criteria was that hospitals struggle to get those scales that do measure only in kilograms or have the capability to lock in kilograms. And then, some of the pros are that, as Michelle said, it improves patient safety. So, we had an average score of 4.7, a range of 2. So we're not that far apart in terms of thinking that it's important and it should be included as minimum criteria. But there's still some folks with some reservations. So we want to provide some space to talk through that or discuss any edits to the proposed criteria, maybe more specific or how you would like it to read, to be considered in the next round. Feel free to come off mute and share with us. Or maybe some of the folks who may have scored it a little bit lower. What reservations do you have about including weighing children in kilograms as a minimum criteria? Noting it's a safety issue. Thank you. Is there folks who feel like it would be a barrier for sites to become pediatric ready if it was a requirement? And if so, how might we address that?
One of the things, Kasey, is even if you're using a weight-based tape, like Hand Heavy or Broslow, those are also set up as kilos. Just for awareness, for those that don't know that.
It's like Nicolina has her hand raised.
Yeah, I was just going to mention, I've worked with a lot of hospitals in Colorado who've pushed back against this because they feel that it's a cost prohibition to get products that can weigh patients only in kilograms. And we've had really great luck connecting people with their vendor representatives who have been able to reprogram the beds so they get locked out in kilograms, providing them with charts that provide kilograms to pounds conversion that they post at scales. And then infant scales, I will say, have been the one challenge. Oftentimes they are non-reprogrammable, but one of our hospitals came up with a great strategy, which says, here we weigh all of our patients in kilograms, not kids. They actually extended it to all age ranges. So all age ranges are weighed in kilograms and it's recorded as such. And while they're pursuing funding for a new scale, they put a sticker over the pounds button that says, we weigh our patients in kilograms. And we have yet to find a hospital who's, once we connect them with vendors, culture shift, and stickers, they've all been able to overcome this.
That's awesome. We've also, our system has gone for our adult patients as well into kilos, because I think there's some of the adult meds are now based on kilo.
Yeah, the other pushback I've gotten from facilities is no matter how we weigh it, our EMR pushes the information out in kilograms. So granted, in that emergent situation, they're not solving the problem, but they're saying as soon as we put it in, we have the kilograms exact conversion available.
Thank you. I think there's a couple comments in the chat as well. I think saying it's an easier win that hospitals can achieve, and that there's some ways to overcome maybe that initial financial concern of purchasing scales that only weigh in kilograms. Right. Are there any other concerns about the potential of including this as a minimum criteria that you would like to discuss now, or any edits you would like to make to the way that the criteria is presented? Any other comments you would like to add to be included for the record as well? You can make note of those. All right. It seems like generally feel pretty comfortable with weighing children's in kilograms only as a minimum criterion. So we will be seeing this again in round 3. And if you have recommendations to the way in which the criteria is phrased, go ahead and put it in the chat and let us know, and we can include those as well. So hearing nothing else, I'm going to go ahead and move on to the next criteria. So the next one is weighing and recording children in kilograms only. So we have evidence of 4.7, a score of importance is 4.8, a score of feasibility is 4.5, and overall average of 4.7. The range was a little bit larger as 3.3, and again, we had 39 responses. I don't know, Cynthia, if you want to speak to your comment a little bit more or share some insight on what you have there. Between the last criteria, which is weighing children in kilograms only, and this one is weighing and recording, they both have the same overall average score, but our range of the scores is a little bit wider. So we're not as close together in agreeing that this should be considered as minimum criteria. So that's what we're looking at when we're considering the range of the scores. So this one's a little bit further apart. There's more people on, the positive side, and those that maybe don't think it should be included as minimum criteria. So maybe speaking to whether or not you feel like they should both be included as minimum criteria, or where do you stand about considering this one?
I'll just add a comment. I think Nicolina was speaking to this a little bit, and I know there's been asks of how can we work with EMR EHR vendors to make sure that pounds and kilos are not both reported. Sometimes EHRs, electronic health records, will do automatic conversion even when kilos is entered, so that both pounds and kilos are displayed. So this particular measure would require that hospitals work with their IT departments to ensure that the EHR does not display both. And Nicolina, I know you kind of referred to this in your previous comment, but can you share a little bit about vendors that some of the Colorado hospitals have worked with?
Yeah, and I would just like to clarify when I say this, I'm not, speaking preference over any one vendor. So right now in Colorado, the majority of the majority of hospitals that we have utilize Epic, excuse me, and Meditech. And I have not heard of any issues with Epic, which doesn't mean that it doesn't exist out there, but specifically Meditech did require a little bit of finagling to get it so that only weights appeared in kilograms. And it felt like it was an insurmountable challenge until one of our hospitals went to their IT team, who then connected with Meditech, and they found a solution very, very quickly. So I think this is another example of when you're bringing your team together at a hospital to work on pediatric readiness, having your IT team at the table, not just your ER staff, can be really beneficial. Now that we've found that fix, we just refer everyone over to this one very helpful gentleman, and he provides them a path, and it gets resolved usually that day.
Always good to know the right person to ask.
Yeah, and I think it's just, yeah, and I think it's also just an example of going to the person in your facility who does those things instead of trying to strong arm it through the system. It's also, I think, another example of cultural adoption of policy change. Instead of making a policy that's the only way it's going to happen, they fixed the ways in which people could enter that data. So it became a part of their culture. In addition to, we weigh our patients in kilograms, we record it. They made it feasible for that only to happen.
Thanks for sharing that.
Comments in the chat about increasing electronic health record use, recording kilograms is equally important for reducing medication errors. That's a great point as well. Morgan mentioned that most of your EDs and EMS both have pounds and kilograms displayed in their electronic medical records. Do you feel like feasibility then would be low? It is interesting to see our scores for evidence, importance, and feasibility don't have that wide of a range. So whenever we reviewed our results, we're all within a point of each other. For those who feel like it's not a criteria which should be included as minimum, maybe you want to share your input to the group or how you feel that it would impact a site's ability to become pediatric ready in your state or territory. And since it doesn't feel like they have the power to make the vendors change. That's a great point, Jessica. There would be a point of duplication. So this is sort of that category of weight in kilos. If we're talking about what is the minimum, is one the minimum? Maybe one's for another level of recognition. And how would you like to consider that as well? Any other thoughts or edits you would like to make to this criteria? The discussion today will sort of aid in future rounds of voting and how we consider these criteria for minimum recognition. Right. Any last comments before we move on? So our next criteria is the at least one PEC. So again, if we go from our top, we have average evidence score of 4.5, importance of 4.7, feasibility of 4.4. So we have a little bit more of a spread there of importance to feasibility, and then the average was 4.5. The range of this score was of a 4. So we had folks who voted it as important or very strongly agree as a 5, and then strongly disagree as well. So we have the range of the 4. So quite a lot of spread on our group's thoughts in considering PECs as minimum criteria. So maybe you'd like to hear from folks who really feel like this should be considered as minimum criteria and those who feel like it should not be included as minimum criteria.
Just as a reminder, this is what I believe 90 or 95% of current recognition programs have at least one PEC, if I am remembering that correctly, Kasey. So,
Pulling on I feel like that number might be for EMS agencies at that percentage. I don't know, Julie, if you can go back and double check our slides from one of the first sessions. But it was one of the items that was identified early on as being included in many of the recognition programs.
And I think there were some comments around evidence for some of these pieces, just that was shared during the prior sessions, but just as a reminder that the presence of 2 PACs is associated with an average adjusted 16-point increase in overall pediatric readiness, and even having 1 PAC is associated with improved overall readiness.
Jeff has a recommendation to consider this as the minimum criteria and then specifying one for each. And then for each, are you speaking to like an RN pack and a physician pack? Okay. At a higher tier. Great point. The packs are the advocates. Joshua, do you want to speak a little bit more to your experience in interacting with some of your sites and maybe not having a PEC?
That'll be fine. With us, we have a significant amount of poor rural hospitals. And the way that they operate is they utilize nurse practitioners as their primary care providers inside their emergency rooms with an offline medical director who is over the hospital. That person sometimes is or is not officed inside the hospital. A lot of times it's a general practitioner from the community. So therefore, for us to have a physician who is a PEC would just be impractical and almost impossible for these smaller hospitals, and they wouldn't be able to participate in the program. One of the suggestions that I have heard through our committee was simply to allow the base level PEDS ready hospitals to utilize a nurse practitioner inside the emergency room or a registered nurse who also is active inside the emergency room. Someone who has the skills and capabilities and is already there and is also willing to do it rather than strictly requiring a physician.
Thank you for sharing. It's like we have some folks agreeing with their experiences similar to yours. I think this proposed criteria is at least 1 PAC. It's not specifying that needed to be the RN or the physician PAC. So hopefully that would provide some more flexibility for sites like that. So would you feel like this would be a better option, or do you have another proposal about how to maybe consider PACs as minimum criteria?
I think one thing that we can do, and this was coming from my advisory committee, is to change the language and have it a advanced practitioner as being our PEC requirement rather than a physician. And again, this is going to be a minimum criteria, which we would utilize for what we're calling our pediatric community hospitals. The higher levels that have more capacity and capabilities would be utilized or be required to utilize a physician.
And would you see that at a higher tier or at the minimum tier of recognition?
The higher tier will be a physician. The minimum tier would be an advanced practitioner.
Okay. Right. Looks like more provider, not just physician. So currently it's at least 1 PAC. So there is no specification of provider, nurse. It would be anybody within the ED identified as a PAC might meet this criteria for minimum recognition.
Just a comment that it seems like saying at least 1 PAC provides flexibility for all of the comments that were shared, making this either in their specific criteria, a nurse or provider, an advanced practitioner, or physician, or whatever the language is that a state would choose.
But do want to make sure we're able to move on to our next section of today's PRRPC session, where Julie will give us goal setting. But if there are any recommendations on how to update this criteria for consideration for minimum recognition criteria for EDs, go ahead and put that proposal in the chat and we'll go back through and locate it so that it can be considered in the next round. But we will be asking for an evaluation, a short 3-question poll after our next session, so that we can get your input about how this session went today and whether or not we need to go back to the drawing boards and consider a different way to go about approaching this concept of one session, but allowing for multiple breakouts. So thank you all for your input today and your feedback. Look forward to working with you all on this more. And go ahead and hand it over to Julie. And Julie, I think you're still on mute.
Okay. So thanks, Kasey. So if you're just now joining us, this is going to be the second part of our 3-part session. And we just finished with the ED minimum criteria discussion, and now we're going to talk about setting goals. So if we'll go to the next slide. Once again, we thank you for joining us. The session is still being recorded. You can still use the Q&A and the chat feature. And we are going to make this interactive again. So hopefully you will join us in this fun activity we have. So we just finished with minimum criteria for ED. We'll finish that discussion. We'll continue next time with and continue that discussion in February. Today, right now, we're going to talk about goal setting for the next few minutes, and then we'll finish up with the minimum criteria for pre-hospital recognition programs. So then the next slide. So we're going to talk about goal setting. So brand new year, it's the perfect time to set your resolution, to make your goal. But we want to, and not a resolution, we want to give you a space and give you some guidelines on setting your goal for your recognition program. Whether you're developing your program, whether you're improving by enhancing, expanding your criteria, looking to make sure that your verification process is where it needs to be, or whether you're trying to expand into different areas of your state and get more hospitals or EMS agencies on board. So going to the next slide, if you will remember back in September, we met in Austin at the AGM pre-conference. We kicked off our collaborative session, and we all met in this great big room. And in that time, we heard from Lisa Gray about the implementation phases. So we've got no progress, research development. Phase 3 is the developing your process and your plan. And then you start moving into piloting your program and then formal recognition. And then she, remember, she talked about this bonus phase of beyond phase 5, where you work on expansion and enhancement. And then afterwards, we went into a breakout session and you divided up into groups according to what phase of development you identified with at that time. And then we even went further and focused on ED or pre-hospital recognition programs. And so moving to the next slide, we take the slide before and we take the 0 through 5 arrows and we look at, okay, how do we actually go about doing that? So if we broke those out into steps, Lisa went into detail about each one of these, about each one of the phases and the steps that were needed to meet that research phase. So what does research phase look like. You build your core team. You understand your state and territory and system, and then you inform your partners, and then you create an action plan and timeline, and so on and so forth through each phase. So then we went further. So back to our breakouts. So if you were on one side of the room, we had a big poster boards, and we created this step. We created these maps, but it didn't look like this. It looked like what's on the next slide. So Kasey, if you'll go to the next slide. So it looked like this. So the top in the blue is the ED, and then the bottom was the pre-hospital group. So you'll remember we had the big white poster boards, and we put Post-it notes up, and you walked through each one of the steps within the phases. But then what you talked about was, what do we need to do to build that core team? So in phase one, building that core team, what does that look like? And so the ED side did this, and then the pre-hospital side did this. And we looked at who are your key players? Who are your thought leaders? Who can you reach out to for this recognition program? And then, so ED, you can see they went through all the way through phase 3 and did this. What do we need to meet each one of these steps? Pre-hospital side, I heard a lot of the discussions, great discussions, and they got through understanding your state and territory system. So I want to point out here, this process map is what these are called. This is a mapping out the process. So you want to develop your program, or you want to improve upon your program. What are the steps that need to be taken to make that happen? And so that these are the steps, and you've mapped out that process. So on the top for ED, there's one part in phase 2 that is the third step in phase 2 is determine criteria. And Kasey, if you'll click the button again, I've highlighted this. Wherever you are in your development, improvement, whatever phase you're in, we've jumped around a little bit with the collaborative and went to this step. So if you haven't gotten to this step, you've jumped ahead. We're going to go ahead and help you along with that. If you're farther on the development phase, then you might need to step back. But either way, it's part of the improvement process to determine the criteria. So if you look at this back in September, these are the things that you said, this group said that needed to be done to determine the criteria. You engage with the HRSA program officer, know your resources and your evidence. Make sure your criteria is realistic. So that's really what we're doing in that minimum criteria consensus process that we've been doing. Okay, so why do I tell you all this, and what does it have to do with goals? And we'll go to the next slide. And we'll go back to this. So if you look at your process map, so we've kind of got this overall process map, you can look to see where your state and where your program is in this map. And then you can look to see where you want to be. So where are you now? And then where do you want to be? Where do you want to get to? Ultimately, yes, of course, we want to get to phase 5. We want to celebrate. We want to get to the point where we can improve upon our program. If we're improving on our program, we want to continue doing that. But we can't just snap our fingers and make that happen tomorrow, or maybe even next week. So if we write the plan down, we have a goal, then we know how to get to that next step. Okay. So again, January, great time to make those goals. So how do we go about doing that? So we're going to go to the next slide. And we're going to talk about creating a goal for your state's recognition program. So if you take the process map and you figure out, okay, this is where we are now. Maybe you already have an idea where you want to be this year. Maybe you have an idea of where you want to take your program this year. But consider writing it in a goal format that is very specific. So Kasey, if you'll click the button. So making sure that you are specific when you write your goal. What do you want to accomplish this year? Do you want to move from phase 2 to phase 3? Or maybe you're at the beginning of your phase 2, your communication, and you want to get to the end of phase 2 and be able to define that verification process. That's your first goal. And then you can move on from there. So be specific in where you want to be. And then if we click again, we want to think about how are you going to measure that? So really, you're there, or I want to move from phase 1 to phase 2. That's what you're measuring. Did you do it, or did it not happen? And then clicking again, you want to ask yourself, when you're creating your goal and you're thinking about where you want to be, what other priorities do you have? We've heard, we know that you have a list of things that you're required to do, that you need to do, that you want to do. So where are the priorities around this goal? And take those into consideration when you think about your goal, how big you want it to be, or do you want to just jump from one step to the next? Think about your resources that you have. What support do you have, and what do you need to make this goal achievable? And then clicking again, of course, you want to make sure that it's relevant. We can make these goals really big. We want to save the world. We want to make sure that we have both recognition programs in place. But is that relevant to your state? We've heard from you several times that your advisory board isn't ready for this yet. So making sure that you talk to your team and your stakeholders about what is relevant to your state at this time. And then finally, make sure that your goal is time bound. So how good do you want to be? Like, how much do you want to improve? By when? So if you'll click again, Kasey. So this last check mark is making sure that you put a time in there. So if your goal is to jump from phase 2 to phase 3, you might consider giving yourself 3, 6, or 9 months, or even a year to make that goal. And that will, taking into consideration your priorities and your support, that might determine your goal. So having said all that, we're going to practice. We're going to practice making goals. So Kasey, if you will bring up, we're going to try an activity. Bear with us. We're going to be flexible. We've got a whiteboard prepared for you. Let's see. So, I'm playing with the Zoom feature over here on my end because that was hard to see. So you might want to, in the bottom right, look at your zoom in and out. So here we have, see a lot of names moving across the screen. So y'all are already playing good. So you've got sticky notes on the left. If you'll look at the top line, it says objective. In the orange, we said, what are we trying to accomplish? The blue is how will you know it's successful? The next question we're going to ask is what resources are available to support the objective? Then we'll ask, is the objective relevant to your overall goals? And then we want to know how long it will take. So we're going to do this for each one of these objectives for as long as we have time left in our session. And then we'll come up at the end with a goal, taking into the answers into account from all those questions. We'll see if we can create a goal. If my screen doesn't move around too much. I don't know what's happening. Sorry, it zoomed out on me. And it's moving around. So that very first objective on the left, it says to implement a disaster plan. So this is our example. The objective is to implement a disaster plan in my hospital. So what do I want to accomplish? I want to implement a disaster plan at my hospital, and I want it to have pediatric considerations. So how am I going to know if that's successful? Well, it's either implemented or it's not going to be implemented. What resources are available to support the objective? I have PPN, I have examples from other hospitals, I have experts, I have fellow colleagues that can help. So is the objective relevant to your overall goals? The hospital's goal is to be better prepared for disasters. So yes, this is something that I can do to be better prepared for disasters in my hospital. How long will it take? I expect it's going to take about 9 months. So I take all those answers and I come up with a goal of by September 30th, 2024, that's 9 months from now, my hospital will implement a disaster plan that includes pediatric considerations. So I take that goal and then I go and I figure out how to make that happen. And I create the action plan. So, but we'll talk about that on a later session. All right. So if we'll go back. Okay. So let's talk about developing a recognition program. So maybe you're in phase 0, 1, 2, 3, and don't think about it you specific right now. You can do that offline, but we're going to create a goal as if we were a state program manager and we wanted, or in a team and our goal, our objective is to develop a recognition program. So what specifically do we want to accomplish? So if you want to take a sticky note from the left and drag it onto that second yellow box in the column, maybe you have some ideas. What do you think you would really want to accomplish in developing a recognition program? And it could be as simple as I want to develop a recognition program. I want to develop an ED or specifically a pre-hospital recognition program.
I've put some over here so you guys can just right click on them and then begin typing in the sticky notes.
Is it working? I wonder if we might need to call some ideas out. Has anybody tried typing?
Unable to type.
Unable to type.
Okay. If you let us know, I can type it for you.
So if you have some ideas, why don't you unmute or type it in the chat? And we'll have Kasey.
Or you may be able to now. Go ahead and give it another try. All right. If you're unable to type it, you have an idea of what you would want to accomplish, go ahead and come off mute and let us know. So we'll put it in there for you. See, identify pediatric champion or point of contact.
So I think on the left-hand side of your screen, you'll see an annotation box and you'll have to click on the text, the capital T, and drag it over to where you want to write something in, and then you'll be able to add text.
Hmm. What other ideas do we have to put in that first square?
So what do we put, develop a pre-hospital recognition program?
Got to identify the PAC or the point of contact for each hospital. Feel free to just come off mute and share too.
And so this is big picture right now. It's specific, but we're creating a goal. So it's a specific goal. Oh, somebody's typing. Is that you, Kasey?
I think it's Kate. Develop an, it's very tiny font.
Does this say application process?
Yep, for hospitals to apply.
Okay, nice. Let's do one more.
Reach regional or statewide consensus as to whom the recognition program is hoping to serve.
Okay. And then I'm gonna suggest one more is that we look at ED or pre-hospital. So I'm gonna do pre-hospital. I think I put it in the wrong color though. Okay, so we have some specifics about what we want in our goal. So how are you going to know it's successful? And we do have another specific accomplishment. We're meeting, want to meet with healthcare coalitions and hospital and geographic areas of the state. So as Kasey's typing those in, how are you going to know that the goal is successful? If you were to meet all of those specifics that we've written down in the first column, in the first row, would there be a way to measure success? If you were able to accomplish those or not accomplish those, how would you know that you did that?
This is considering a state or territory who's going from having no recognition program to implementing a new one, correct?
Yes, yes. So think about your program. If you're looking at your wanting to accomplish developing that application process. You want to meet with your healthcare coalitions and hospitals in the state. You want to reach that consensus of who the hospital's hoping or the recognition program is serving. What does that look like if it happens? This is a tough one for when we're developing a recognition program, because it's really, it happens or it doesn't. A lot of times you can look at data and look at that. But maybe you want to move from phase 0 to phase 3 or phase 0 to final recognition. So something like that could go here. Okay. Move time, we're going to move on. What resources are available to support the objective? So what resources would you have as a state partner program manager and team? What resources do you have to meet what you want to accomplish? Nice. So regional consensus or regional census, you would know it's successful by looking at a percentage of each district. So what resources would you have and do you have available to make that happen? I know y'all are all probably thinking this collaborative, so we can go ahead and write that one down. You've got the experts, you've got your colleagues on the this collaborative. Utilizing other systems of care, absolutely. Other states. Okay. Right. And then thinking about this objective of developing a recognition program, how you're going to do it, what you really want to accomplish in that objective, in that program development. Is it relevant to your overall goals? So this is going to be difficult to answer on a large group like this because you're different states, and the objective might meet some states, but not others. So we'll leave that one blank. And then think about how long will it take? Let's say it's going to take we'll say 12 months. Because we're starting at phase 0, and we want to move, and it may take longer, but just for the sake of this, we're going to say 12 months. So our goal might look like by December 31st, 2024, my state I can't see the original, so it's hard for me to say this. My state will develop a recognition program for pre-hospital, including reaching regional and statewide consensus, meeting with HCCs and hospitals, so our goal is by December 2024, my state will develop a pre-hospital recognition program, including regional and statewide consensus and meeting with regional hospitals. It's specific. We can measure success looking at, does it happen or does it not happen? It's achievable because we made sure that we looked at our resources. It's relevant to my state because it is a something we're supposed to do. And it's time bound because we've got a time on there. We're going to do this by 2024. And so this is one example of being able to create a goal. And then from here, we have our goal. It's time bound. Now, how do we make that happen? How do we go about those steps to accomplish our goal? So tough exercise we thought that would work out a little bit better and be a little more collaborative, but we'll work on that and maybe next time have a better, so we can hear from y'all a little bit more. Okay. So thank you for that. So we're going to move on to, and if you are hopping off, our next session will be in February. So between January and February, you will touch base with your collaborators if needed, your stakeholders, and then consider and draft your goal for your recognition program. So go ahead and look at that, draft that, and reach out if you have any questions or want to send it to myself or Kasey or Laney to see if we can help with that. And then in February, we'll continue reviewing round 2 results and looking at those measures. So next slide, we'll move into the pre-hospital recognition programs minimum criteria discussion. So again, if you're just joining us, we've broken this out, the full hour-and-a-half session into 3 separate parts. The first 30 minutes, we discussed minimum criteria for ED recognition programs. The second 30 minutes, we looked at goal setting and created a goal, tried to create a goal. And then the next 30 minutes, we are going to discuss the minimum criteria for pre-hospital pediatric readiness recognition programs. And so we can go to the next slide and I will hand it back over to Kasey.
Right. Thanks for sticking with us through this. If I can I get if you're just joining us, meaning you weren't here for the hospital minimum criteria discussion, can you go ahead and raise your hand? Raising your hand if you're just joining us for the pre-hospital consensus activity discussion. Meaning you weren't here for the hospital. Right. So don't see any hands raised. So you've stuck with us for the whole hour and a half. Appreciate that. All right. Well, then we're in the same place with the pre-hospital criteria. We've completed the round 2 ranking and we're in the analysis of results and feedback stage. So again, we're going to plan to discuss and edit the proposed criteria in preparation for the 3rd round of this consensus activity. Any questions about the process up to this point or the next steps? Again, if you do not have access to your state's results and you would like them, go ahead and message Eleni and she'll get you the link to your state's results. And then also you should have received yesterday the overall results as well as some comments. It might make it a little bit easier to follow along as we look at the next slide. So here we have the proposed minimum criteria for pre-hospital recognition programs. And we have the overall average, our average maximum score, our average minimum score, and then the range or the difference between the maximum score and the minimum score. So we're looking again at this list in order of those with the highest average and the smallest range. And the items highlighted in red are the ones that we're going to start with discussing today. So we wanted to start with some of the ones that had high scores and average, pretty consistent in how we feel about it and its consideration as minimum criteria. Then we'll move along and discuss some of the ones that have a lower average and a wider range. Any questions about this table or how we got these results? Chat. Eleni, can you help Rachel with the link to the overall results? She should be able to get you that link here in a second. All right, so our first criteria being considered for pre-hospital recognition is that it requires training on medication dosing for children. So the same setup, we have our average evidence score, which is a 4.6. The average score for importance was 4.7, and then feasibility was 4.5, with an overall average of evidence, importance, and feasibility is a 4.6. We did only have 33 responses for pre-hospital criteria. So 33 states and territories provided input. And then the range of our scores was a 2 for this criteria. We have some of the comments that we collected. Some that they might already be in place. This criteria is already in place. But training should be quarterly. So maybe an additional consideration would be the training and how often. And some general comments as well. So I'd like to open the floor. Again, have a discussion. Maybe we hear from some of those individuals who felt strongly that it should be considered as minimum criteria and those who feel like it should not be considered as minimum criteria. This is also an opportunity to make any edits or changes to the verbiage or the way in which we present the minimum criteria. I think one of the ones that came up before was making it as applicable, so not excluding BLS agencies. So I don't know if someone might want to speak to that more or how that might come into play. Maybe reviewing your state's responses, especially some of those states that might have had other individuals providing input. Your state or territory in line with including this as minimum recognition. They sort of feel like it maybe shouldn't be included at the minimum level. Okay. Well, in the interest of time and to be able to share some of the other criteria, if it did have a high average and a low range, so there was a lot of consideration or individuals or states who considered it as criteria which should be included as minimum criteria. Go ahead and move on to the next one. All right, the second criteria to discuss is using weight estimation systems. So it's being considered in pre-hospital training programs, some of these items. So using a weight estimation system, we had a lot of comments about this one. If you have access to that document with the overall results. The comments are also included in that document, so it might be easier to read. But estimating weight in pre-hospital settings is often difficult and can be inaccurate. Utilizing tools and estimation systems can help improve this, reducing medication errors. So sort of speaking to the evidence, which our evidence scores a 4.5, an importance of 4.7, and a feasibility is a 4.5, with the overall average of 4.6. And the range for this was a 2.3, again, with only 33 responses. So again, a fairly high average and a range that is not very wide. A lot of the discussion about some of these was the inclusion that they're already at the state level and how that might play a role into considering these as minimum recognition criteria. I don't know, Joshua, if you want to speak to that more, do you feel like that leads you to include these as minimum criteria because they're already a part of these other programs?
Yes, with our state systems of care, specifically the trauma systems, all of this is already included in requirements for all pre-hospital agencies, whether it be transport or non-transport agencies. They have to have specific pediatric training on dosages for a wide range of medications, and they also are required to have some sort of a weight estimation system. To obtain an ambulance license in our state, you have to have these things on board, and you have to have proof that your personnel have been trained in it.
So Josh, does that mean it's an easy yes for your state, or are you saying that you're opposed to it because it already exists?
No, it's an easy yes to our state, and I've utilized this stuff when I try to increase buy-in, simply because we take it and let folks know that they're already doing most of the things that we're requiring. That way it's much less effort on their part, therefore less expense, whatever we can to make it more feasible.
Yeah, I think that was common feedback we received, was that it was considered some other agency or some other point. That sounds like we might see that as a positive, as including that as minimum criteria then. Any recommendations to changing the proposed criteria in the way that it's worded, or adding additional elements to it? All right, move on to the next one then. Next one I wanted to discuss today was having a designated PEC. A lot of feedback on considering PECs. We had an evidence score, average evidence of 4.3, importance of 4.6, and feasibilities of 4.2, an overall average of 4.4, and the range of 2.7. So again, hopefully you have that document open and reading some of the comments. I think, Cynthia, maybe if you'd like to come off mute and share a little bit more about that.
It's actually for the previous slide, so I'll let you
Okay.
guys integrate it.
Dwayne, it looks like the PEC is a concern for the smaller non-transporting agencies. Anyone else second that, or maybe have thoughts on how to overcome some of those concerns?
Kasey, I'll just qualify that the way to overcome it, we've tried to get them to collaborate with their BLS or ALS transporting services in their area, but that's not always an easy sell, but that's our solution. We've got over 400 non-transporting QRSs in the state, and that is a challenge alone, let alone the staffing and getting them to have components like a dedicated individual who can take care of PEC. Knowing that these agencies are only at the EMR level, a lot of this is beyond their scope in many cases, and therefore not always applicable. So it's a challenge.
Appreciate that. Maybe do we have an advocate who feels strongly that the PEC should be included as criteria? Issues with staffing or regional PEC. Does anyone else have experience with the implementation of a regional PEC?
Hi, this is Sam from Michigan. So, to answer your question, Kasey, and to Josh's point, so we have several regions in Michigan that are extremely rural. We have a lot of MFR and volunteer fire-based agencies, and pretty consistently in those two regions of our state, they use a similar approach. We don't necessarily call it a regional PEC, but most of the models come from either a health system based or a medical control authority or a regional pediatric champion that represents multiple agencies. And so it's just like a second line of communication at this point. But those problems that are being raised, that's one of the ways that we're getting through it. I think as long as it's clearly spelled out that a PEC or a pediatric champion can absolutely represent multiple locations, I think that would help get at some of the issues with rurality, time, personnel, and volunteer and MFR status. Maybe not for everybody though, right? But it does significantly help here. And we've got a huge area of rurality in Michigan.
Yeah. Would you guys like to consider making that as an addition to this criteria? Or do you feel like a designated PEC is covers sort of all of those situations, or propose maybe any edits to the criteria that would better speak to those situations and be ensured to include them?
This is Kelly from Illinois. And, I feel like with anything, whether it's pre-hospital or hospital, if you want to get traction for any sort of a pediatric recognition process, program, whatever, there's got to be one key individual, whether they are at a single agency or covering multiple agencies or a region or a system or whatever, that is that key point of contact and that key individual that's going to keep pediatrics on the forefront. Because without that person, that individual that has that focus and that passion to ensure that any criteria we move forward with saying is important, it's going to fall through the cracks. So I don't think removing having a designated PEC is an option. There needs to be flexibility as to how that role is managed or covered to meet everybody's needs, but there's got to be a PEC. I just don't think there's a way around that.
Thank you so much. So it sounds like we might be able to make an edit to the criteria. So we consider a designated PEC. I feel like regional is a term in which multiple states and territories might be able to implement and utilize in their own way, or is there another way in which you could see it being stated?
One thing that we've gained a lot of traction with here in Mississippi is utilizing the training programs, our EMR, EMT, and paramedic training programs as PECs for an area. They already have everything in place to do the skills affirmation, and most programs are already training up under their national registry license and so forth. So it works out fairly well to be a convenient thing for our system.
That is a great way to look at it. What thoughts do we have on this proposed edit? See if I can make it so you can all see it. So designate PAC who may support one or more agencies. It might work for some states. Great question, Dwayne. What is a PEC? Do we feel like there is more need to outline what the PEC is in the criteria, or maybe provide a different way of explaining that? There's a definition in the EMSC program manager manual. Great resource. Okay. Any other comments on considering a designated PEC who may support one or more agencies? We have one more criteria I wanted to look at today. And that was considering a quality improvement plan that includes pediatric considerations. And our average evidence score was a 4.2, an importance score of 4.2, and a feasibility score of 3.9. Overall average of a 4.1, a very large range of 4. And quite a few comments. Well, again, I'd like to open the floor, hear from some folks about thoughts considering a quality improvement plan as minimum criteria. Cynthia.
Based on the work that we saw from Dr. Caleb Ward at the meeting in Austin, I think this is a huge ask of an individual company with no template. But if there is going to be a NEMSIS pediatric dashboard that is available nationwide and has the report writer, the data points to pull, all of that already built into it, and I know that Clayman's team has the ability to do that, then I think it is a criteria to say maybe within the first 2 years, or I don't have a time frame in my mind, but to say build this from scratch at a county EMS career agency, they've already got it. But to do it based on a national model and select one metric to follow each year, that I think is reasonable. So I think a lot more information needs to be put into this before it would be essential.
Yeah. And Nicolina?
Yeah, I just want to follow up on some of Cynthia's comments. I agree with her, and having worked at a very small agency from when I started as a volunteer to when it became professionalized, I think that we oftentimes forget that leaders in our EMS agencies were oftentimes promoted because they were good at being an EMS provider, not necessarily having leadership tools and the tools to help the agency along. And so recognizing that quality improvement oftentimes gets implemented as quality assurance, assuring that if we feel this is imperative, that we give tools that help these agencies, especially the smallest ones, build. Sorry, I'm stumbling over myself. We give them the tools they have to build a program from the ground up, because I think we still are seeing a lot of turnover in EMS agencies. Sometimes the last person standing is the person who's taking over the agency, and they don't have the tools. And so we should assume the lowest common denominator here is the agency that has never done quality improvements, and they need to know how. And so providing all of the tools from starting a program from the ground up, using it as Cynthia was talking about at a county level, providing dashboards, whatever we can do for this to be truly meaningful. We need to recognize that there's a lot of agencies out there who just simply aren't doing it, and they need the tools to be able to put it into place.
So much, Nicolina. Any other comments or questions related to quality improvement in the pre-hospital space? There is some, really exciting work coming from the NEMSIS dashboard work.
I'd love to add one more comment, Kasey. I do think the NEMSIS dashboard work is exciting because the data is already being submitted to NEMSIS, so it doesn't require additional submission. But not that I'm condoning this as the most robust QI strategy, but there are certainly initial efforts undertaken where it's simply a manual review of, specific cases like cardiac arrest. And I think this was written in the general comments. And for a small agency that doesn't see that many children, undertaking something like that could mean, reviewing one case per year. So I'm not sure that it is necessarily overly onerous. And I say that as an EMS medical director in the field, but just wanted to share that.
Can be considered maybe as a smaller quality improvement initiative and not a large scale program. Well, for having such a large range of score, it did still have a fairly high average score. So when voting and considering it based on the evidence, the importance, and the feasibility, I feel like it should not be included as minimum criteria. Feel free to vote that lower, and then that'll reflect with a lower average score moving forward in our next round. Any questions about today's process or anything that we've discussed? Do you want to launch a brief poll to get your feedback? You mind taking a moment to fill that out for us? We can continue to align our sessions with your needs. We appreciate, again, all of you attending today, and we will see you again in February. Great day, everybody.